Thank you, Sarah. It's always fun to get to be introduced by somebody you used to work with. When I got the topic for this talk, I thought, oh gosh, do I really do abdominal wall emergencies? And I thought, oh, okay, wait, we're talking about all kinds of hernias, not just ventral hernias. So I do have some experience in this realm, and I do have some disclosures. I trained with Intuitive on the robot in July 2020, so that's reported on Open CMS or whatever it's called. And I've trained as both a minimally and maximally invasive surgeon. I practice as a trauma surgeon, acute care surgeon. I have an elective surgery practice in hernia, and I'm a critical care intensivist, and I really do love the robot. So those are my disclosures. I do want to direct you all to a really outstanding talk from last year's meeting. As I was preparing this talk, I came upon Andy Wright's talk on emergent hernia repair, the good, the bad, and the ugly, which he presented remotely last year because he was unable to attend in person. The link to the video is there, so I hope my slides will be available afterwards. But I think you should definitely take a look at this because there are many options for minimally invasive repair of abdominal wall problems in the emergent setting, including hybrid repairs, and I don't think that we talk about that enough, so I'm going to try and mention that. So in his talk, not to totally repeat it, but I think he presents a really useful algorithm for how to start using minimally invasive surgery, and I think you can superimpose robotics on this. So you start with diagnostic laparoscopy to see if you think that this is possible. And if it's not, if you can't reduce it, if you find something that you don't think that you can fix with the skills that you have or the equipment that you have, we just convert to open. And I don't think there's any shame in that. We're doing the right thing for the patient in a difficult situation. If somebody is unstable, you want to do the fastest repair that you can get to some sort of source control and some sort of stability as possible. But if you can reduce the bowel laparoscopically, do that. And then this follows along imbricating the hernia sac. You can repair with an omental plug. That's a good bailout so that you don't have to try and close the fascia. Really can do that quickly. You can do primary repair with suture, and there are many ways that you can do this. So if you're not using the robot, you can use a suture passer. But if you're using the robot, it really expands what you can do in terms of fascial closure. I'm not sure that most of us would go ahead and do something to the extent of an ETEP or a Robotar in the emergent setting. Those of us who are just getting our sea legs with the robot, I'm certainly not there yet, but I know that there are people that are doing this, and I'm going to talk about that later in the presentation. If you get to the point where you feel like you can't quite do something all minimally invasively, add an open component. You can do a hybrid approach to close the fascia. And then there's the mesh repair, and you can do an IPOM, you can do a TAP, you can do this ETEP plus or minus a TAR. All of these things can be done robotically. It's just a question of whether or not the patient can tolerate the procedure and how long you're going to be in there, whether it's wise to do that. I'm going to add this box because there's so many other options that you can add in here. Really, if you've got a real disaster, you can just deal with the mess and close the skin and come back to fight another day. Bridge, either with bioabsorbable or synthetic. Use a peritoneal flap closure with a synthetic. Transversus abdominis release with retromuscular synthetic. All of these are different options that we have. Some of these can be done minimally invasively. More of them can be done with a robot than just with the laparoscope. So I think that the robot has really expanded what we're thinking we can try to do in the emergent setting. But the bottom line is we really have to think about this like any other acute care surgery case. You've got to manage the acute problem. If the problem is the patient has perforated viscus, you've got to deal with that. And most of the time, we're not going to be dealing with that minimally invasively, although I know Andrea's going to show a video. We want to reduce the perioperative morbidity. So we don't want to make it worse for the patient by spending more time using a minimally invasive method. We need to do a good enough repair. So maybe that means reducing the hernia and just plugging that hernia with an omental patch. That may be the fastest, most expeditious, safest thing to do for the patient. And really, we don't want to burn any bridges. So if you have a lot of contamination, that's probably not a good time to do a robotar, honestly. The chance of having an infection after that seems to be too high to me, and I know that's outside of my skill set. So you gotta know what you're capable of when you go into these emergent situations, and don't invent something new that you wouldn't do in an elective situation. Gotta adapt to the circumstances and the patient preferences. So that's the end of Andy's talk. Thanks for coming to Andy's talk. Let's see if I can advance this. Before I came here, I actually created a poll in the Robotic Surgery Collaboration Facebook group because I wanted to know what people were doing. So before I really delve into what the answers are, let me just say that this is a biased sample, right? These are robotic surgeons. There are over 13,000 members, and obviously not all of them are surgeons, but these are people that love the robot. It's an unscientific poll because the total views of this poll are unknown. I don't know what the denominator is, but I think it is interesting to see what people say that they do most often. So I gave a bunch of different options of things that you can do with the robot. Would you do an incarcerated inguinal, including femoral, with mesh placed extraperitoneally, so a TAP or a TEP? Would you do an incarcerated ventral incisional hernia with mesh? How about an incarcerated umbilical with mesh, incarcerated umbilical for reduction and resection only, a robotic suture repair and no mesh, et cetera, and went down the line. And you can see that like 78 votes for the incarcerated inguinal. So, you know, those gateway cases, you're doing them to learn how to use the robot. We're all doing inguinal hernias. I think most people get to the point where they are comfortable doing the incarcerated inguinal hernias. And I definitely think that this is a great use of the robot in acute care surgery. There are cases that I have done with the robot now that I would not have been able to do laparoscopically. I think that there's a way to really utilize those after hours open robotic times by bringing patients in that maybe wouldn't normally be coming into the emergency room who have an incarcerated hernia, and getting them done and getting them fixed and feeling better. It's interesting, though, that in this poll, there were fewer than 10 votes for a hybrid robotic open repair of any kind for any hernia. So I don't think people are thinking that way right now. I think maybe the concept is if you're going to use the robot, you're going to use the robot and we're going to stick with it. And to convert to open would be sort of, you know, a conversion, not a hybrid. But I think the bottom line is that surgeons are out there using the robot for incarcerated hernias, and I would imagine that this means they're doing it when they're on call. So there are only 2 papers in the literature that I could find about the use of the robot for robotic emergent ventral hernia repair. Dr. Kudsey is the first author on both of them, and I'm just going to go through this one paper because the other is sort of a reanalysis of the same data. So their primary objective was to compare postoperative outcomes in patients undergoing open and robotic ventral hernia repair in the emergent setting. They had 78 patients that qualified for this in their database that they'd been keeping for about 10 years. They had 43 open repairs and 35 robotic repairs. And you can see that the 2 groups were fairly similar. The only difference really was that there were more incisional hernias in the robotic group compared to the open group, and the hernia locations were about the same. So the robotic group had less incarcerated omentum and more incarcerated colon. They used a much larger piece of mesh to defect ratio in the robotic group, along with more synthetic mesh. They did not use any transfascial sutures in the robotic group, but did in the open group, and there was more non-fixation in the robot group. I thought it was interesting that it was twice the operative time, but they were still fast with a consult time of about 2 hours. And they had fewer major complications, including return to the OR for surgical site occurrence. So I think this is a compelling paper. Obviously, it's very early for us in this transition to robotic emergent repair. But I think this is exciting to see. He also has a case report about robotic inguinal hernia repairs for incarcerated hernias. And what I'll say about this is that I think it kind of echoes my own experience. Like, people do really well when you do this operation. Some of them can be very difficult. He didn't report any bowel resections in this case series. And I think it is important to have good technique when you're reducing these. It is challenging to reduce some of these hernias, and sometimes you need somebody at the bedside helping out, putting some pressure on the groin while you're trying to retract. And I'm going to talk a little bit about that technique in another slide. So all in all, I think this is an interesting case series. Many of his patients didn't require any pain medicine at all. Remember, these are incarcerated hernias. The mean hospital length of stay was 1.4 days. There was 1 ICU admission, 1 readmission, and no recurrence in a 31-month follow-up period with no surgical site complications. And I know we can't say that about emergent open inguinal hernia repair. Obviously, this is somewhat of case selection. We don't know which patients didn't get a robotic inguinal hernia repair that were incarcerated. But I think this, again, is interesting and hopefully gives us some promise that we can continue to do this. I'm not going to show this video because I couldn't get it off of YouTube, but this is a video from Conrad Balliser, and basically what I would encourage you to do is watch this because it does show some critical moves in doing that first step in particular. You want to isolate the distal segment of the incarcerated loop of bowel and retract using graspers on the mesentery and not on the bowel wall, if at all possible. Again, using a lot of sort of blunt retraction without grabbing also works. With a partner pushing on the groin sometimes can help. And the worst case scenario is that you have to divide the inguinal ligament. You want to inspect the bowel viability. Dissect the preperitoneal pocket like you would do in any inguinal hernia, reducing the hernia sac, placing the mesh, and having a peritoneal closure. So, is it possible to use the robot 24/7? I actually went to our robot rep and I asked him to review data from the 3 of us that are in our acute care surgery group that use the robot. So there are 11 of us in our group and 3 of us are robot surgeons. This is robot surgeon number 1, and you can see that this person does 3% of their cases while they're on call before the morning block, and another 11% of cases when they're on call at night, and 6% of their cases on the weekend. So that's a total of 20% of their cases are being done out of block time. Robot surgeon number 2, 19%. Robot surgeon number 3, 41%. So one of my partners has made it his mission to make our program work. And so every time he's on call, he's looking for an opportunity to make his case a robotic case. I've done about 7 appendectomies, a bunch of choles, carcerated hernias, a couple of lysis of adhesions. I'm not a colorectal surgeon, so I'm not going to be doing those cases in the middle of the night with the robot either. But I think that you can see that you can transition this. Now, what does it take to be able to do 41% of your robot cases out of block time? It takes a can-do attitude from your team. That's what it takes. It can be a better opportunity, better operation for the patient. It's new experience and more experience for your call team. There's no competition for the robot at 2 a.m., I can tell you that right now. You get more clicks for you, your resident in the facility, and for us that makes a big difference because we want to get another robot, because we just do not have enough block time. So for us, it really does matter. But again, it's a challenge to get your call OR team to be able to do this. Part of our deal working on having a robotic program was that we would have a call team that was willing to do this. You need to know where everything is, though, because sometimes people will not be able to find it in the middle of the night. And you may not be able to have that special instrument that you really want, so you got to learn how to use those 3 main instruments that we like so much. Planning for the unavailable and the unwilling, and patience and grace go a long way to making it work. So I would say yes, there is a role for robotics in abdominal wall emergencies. Thanks.